Hello, welcome to Dental PYQs. Today we are breaking down the July 2015 RGUHS Human Anatomy paper. So let's begin. So the first question here is the muscles of tongue, okay, which is a 10 marker. Now they've given us 5 subheadings, which is origin, insertion, nerve supply, actions and applied anatomy. So they've already given us 5 subheadings, which means it carries 2 marks each. Okay. Firstly, we'll just write a brief introduction of about 1 to 2 lines. Tongue is a muscular organ which is situated in the floor of the mouth. Functions are taste, speech, chewing, deglutition. It comprises of the skeletal muscles. Coming to the muscles of the tongue, okay, we have a median fibrous septa, as you all see in this green color. Okay, it divides the tongue into 2 equal halves. So each half will contain 4 intrinsic and 4 extrinsic muscles. 4 intrinsic and 4 extrinsic. Now this is your superior longitudinal muscle. This is vertical. This is transverse. This is inferior longitudinal. This is styloglossus. This is hyoglossus. This is hyoid bone. Okay, and the largest muscle that you see here is the genioglossus. Now let's look into the muscles deeply. First we'll be covering the intrinsic muscles. They are present in the upper part of the tongue. They're attached to the submucous fibrous layer and the median septa. Now as stated, there are 4 muscles: superior longitudinal, inferior longitudinal, transverse and vertical. Superior is present beneath the mucous membrane. Inferior is present on the inferior surface of the tongue. Transverse extends from the median septa to the margins. It's a straight muscle. The vertical forms the borders of the anterior part of the tongue. Coming to the extrinsic muscles. Again we have 4: palatoglossus, hyoglossus, styloglossus and genioglossus. Here it's very easy to remember the origin and insertion. The first part will give you the origin and the second part will give you the insertion. For example, palatoglossus originates from the palatine aponeurosis and inserts into the side of the tongue. Same way, hyoglossus originates from the hyoid bone and inserts into the side of the tongue. Styloglossus, styloid process and side of the tongue. Genioglossus from the genial tubercles into the side of the tongue, but here we have 3 fibers: upper, middle and the lower fibers. Upper will be tip, middle will be dorsum of the tongue and lower will be the hyoid bone. So let's see the actions now. Retraction. This is going to be elevation. This is depression. And lastly it will be protraction. Now here again we'll see the intrinsic and extrinsic separately. Both the longitudinal muscles, superior and inferior, are responsible for shortening of the tongue. The superior will make the surface concave, while the inferior will make the surface convex. Transverse is responsible for the tongue to be narrow and elongated, while vertical will make it broad and flattened. Palatoglossus. Now देखो, wherever palatoglossus is present above, upper, so it elevates the tongue. Hyoglossus is present below, so it depresses the tongue. Ab styloglossus, styloid process is present behind, so it retracts the tongue. Genioglossus, the genial tubercles are present in the front, so it protrudes the tongue. Here, the name of the muscle will give you the action that it does, so it's easy to remember. Okay, coming to the nerve supply. Here we'll divide the tongue into two halves so that it's easy for us to learn. Firstly, we'll read about the motor nerve supply. And here on this part, we will read the general sensation and taste. So in the posterior most, the middle and the anterior. This is how we will divide it. The posterior most, the general sensation and taste is by internal laryngeal nerve. Middle, the general sensation and taste is by glossopharyngeal nerve. Here the general sensation is bilingual and taste is by chorda tympani. Here all the muscles on this side for the motor nerve supply are supplied by the hypoglossal nerve except the palatoglossus, which is supplied by the spinal accessory nerve of the pharyngeal plexus. Okay, so in one diagram you can summarize both the motor nerve supply, the general sensation as well as the taste of the tongue. So coming to the last part now, that's the applied anatomy. Here they've asked us for 2 marks, so you can mention any 4. Firstly, you can mention about ankyloglossia, that's the tongue tie. It happens because of the short lingual frenum. Macroglossia, as the name suggests, it's the large tongue. Micro means the tongue is small. Cleft is failure of fusion. Tongue deviation could be because of injury to the hypoglossal nerve. Loss of general sensation in the anterior two-third is injury to the lingual nerve. Loss of taste in the anterior two-third is because of the chorda tympani. Loss of taste and sensation in the posterior one-third will be because of the glossopharyngeal nerve. You can also mention the carcinoma of the tongue, which can happen due to tobacco, betel nut chewing, or because of alcohol. You can also mention glossitis, which happens because of vitamin B12 or iron deficiency. Then you can mention leukoplakia. Oral thrush is nothing but fungal infection, that's candidiasis. Hairy tongue, geographic tongue, and profuse bleeding in surgery or during trauma is because of injury to the lingual artery. Okay, so this covers your first 10 marker in brief on muscles of tongue. So the next question is submandibular gland. This again is a 10 marker. They have given us again 5 headings of parts, relation, nerve supply, submandibular duct and the applied anatomy. All these will carry 2 marks each. So we'll write a brief intro. Okay. Submandibular gland is a large salivary gland situated in the anterior part of the digastric triangle. It's J-shaped. Why it is J-shaped is because it's innervated by the posterior border of mylohyoid, which will divide the gland into a large superficial part and a small deep part. Okay? Okay, so just look into the diagram. Now this is the mylohyoid muscle, which divides the gland into a large superficial part. Okay, and this is the small deep part. This is the geniohyoid muscle. This is the genioglossus. This is the sublingual gland. This is hyoglossus. This one diagram will fetch you directly 1 to 2 marks. Coming to the superficial part, it fills the digastric triangle. It has an inferior surface, lateral surface, and the medial surface. Now we can say that the gland is enclosed by two layers of deep cervical fascia. One is the superficial and the second is the deep layer. Superficial layer, it covers the inferior surface of the gland, is attached to the base of the mandible, while the deep layer will cover the medial surface and it's attached to the mylohyoid line of mandible. Again, you can draw one diagram where this is the mandibular canal with inferior alveolar nerves and vessels. Okay, this is the submandibular fossa. This is the base of the mandible. This is the mylohyoid line. Now this is the submandibular gland. ये है medial surface and this is the inferior surface. So the layer here is the superficial lamina. The layer covering the medial surface, this is the deep lamina. The bone that you see here is the greater cornua of the hyoid bone. Okay. So let's cover the relations of the submandibular gland. We have the inferior surface is covered by the skin, platysma, cervical branch of the facial nerve, deep fascia, facial vein and submandibular lymph nodes. Lateral surface, submandibular fossa, medial pterygoid and facial artery. Then you have the medial surface, mylohyoid, hyoglossus and stylohyoid. A medial surface, always remember, has the muscular attachments. So mylohyoid, hyoglossus and styloglossus. Inferior surface, it's overlapped by the stylohyoid and posterior belly of digastric. Again, you can draw a diagram representing the same. This is skin. Okay. This is anterior belly of digastric. This is the mylohyoid muscle which divides the gland into two. This is the sublingual gland. Okay, this is genioglossus. The one duct coming here is the submandibular duct. This is tongue. This is pharynx. Okay. This is the submandibular gland. This is hyoglossus. This is the facial artery. This is posterior belly of digastric. And this muscle here is the stylohyoid. Deep part. It's a small part present at the floor of the oral cavity. Okay, it's related laterally to the mylohyoid, medially to the hyoglossus, above by the lingual nerve with the submandibular ganglion, and below by the hypoglossal nerve. Now coming to the nerve supply, it's a little tricky because you'll have to draw this flow chart which will directly fetch you 2 marks. But just for reason, just mention 3 points that secretomotor fibers are there, sensory fibers are present from the lingual nerve, and we have vasomotor sympathetic fibers from the plexus on the facial artery. ये 3 points लिख के you can draw a flowchart. It will directly fetch you 2 marks. So let's see this flowchart. इसमें we have superior salivatory nucleus which gives the nervus intermedius. Then it goes to the facial nerve, chorda tympani. This chorda tympani joins the lingual nerve, which is the third branch of the trigeminal nerve. Then it goes into the submandibular ganglion where it relays into the postganglionic fibers and at the end supplies the submandibular and sublingual glands. Bus, this flowchart you should draw. Coming to the duct, we have, it's also called as the Wharton's duct or submandibular duct. It's about 4 to 5 centimeters long, 1.5 to 2 mm wide. It emerges at the anterior end of the deep part of the gland. Okay, at the anterior border of hyoglossus, it crosses the lingual nerve. It opens at the floor of the mouth at the summit of the sublingual papilla. 4 points, done. Coming to the applied anatomy, surgically it's very important because whenever there is a surgery that happens to the submandibular gland, we have 2 nerves here which is very important. One is the facial nerve, the other is the lingual nerve. 2 surgically important anatomical landmarks are present. Facial nerve, if there is an injury, it will cause asymmetry of the mouth, that's drooping of the lower lip. If this injury to the lingual nerve, there will be loss of taste and sensation in the anterior 2/3 of the tongue. Now the Wharton's duct, they can have a ductal obstruction, that's a ranula or cyst developing, okay, or there could be any tumors to the gland, or also you can write siloliths. They are nothing but stones. So this covers your 10 marker. Okay, let's move on to the next question. Histology of compact bone explained with a label diagram. So now this is a 5 marker. So we'll just write 1 to 2 lines. Intro. Bone is a specialized dense connective tissue. Matrix is impregnated with calcium salts, mainly hydroxyapatite crystals. Characteristic histological feature is the Haversian system, or it's also called as the osteon. So this is the basic structural unit of bone. It's a cylindrical structure parallel to the long axis of bone. It's composed of 6 to 12 concentric laminae around a central Haversian canal. The Haversian canal is also responsible for the nutrition as it contains blood vessels, lymphatics and nerves. Then we have the lamellae. We have 3 types of lamellae: concentric, interstitial and circumferential. Concentric are arranged around the Haversian canal, which are about 6 to 12. Then we have interstitial laminae. They are present in between the concentric laminae, which consists of old osteons between the newer ones. Then we have the circumferential lamellae. They encircle the whole bone. That means it forms a boundary. Coming to the lacunae and osteocytes. Lacunae are small spaces between the laminae which contain osteocytes. They maintain the bone matrix. Then we have canaliculi. They are minute channels radiating from the lacunae, interconnecting osteocytes with each other and also the Haversian canal. Then we have the Volkmann canal. They run transversely, connecting the adjacent Haversian canals. They also link them to the periosteal and endosteal blood vessels. After you write all these points, then you have to draw the diagram. one big round circle. Then you draw Haversian canals, surround them with concentric lamellae. Then you draw the interstitial lamellae. Then you draw the circumferential lamellae. Okay, so this is your Haversian canal. These are your concentric lamellae. The blue ones are your interstitial lamellae. And the green one is your circumferential lamellae. So this covers your 5 marker on histology of compact bone. Let's see the next question. Boundaries and features of nasopharynx. Now this question, boundaries, will give you 1 mark. Okay. Features of nasopharynx, you can divide it into 2. One is Voldier's lymphatic ring and the palatine tonsil. This is 2 marks, this is 2 marks, and the boundaries will give you 1 mark. So, but still, to start an answer, we'll write an intro of about 1 to 2 lines. Pharynx in Latin is called throat. It's a wide muscular tube. It's about 12 centimeters in length. It consists of 3 parts: the nasal part, the oral part, and the laryngeal part. So it's called the nasopharynx, oropharynx, and the laryngopharynx. The nasopharynx is situated behind the nose. It extends from the base of the skull, from the body of sphenoid to the soft palate, as we see here. It communicates anteriorly with the nose and below with the oropharynx. Coming to the boundaries, anteriorly it communicates with the conchae, that's opening of the nasal cavity. Posteriorly with the pharyngeal wall. Roof is formed by the body of sphenoid and basilar part of the occipital bone. Floor is formed by the soft palate. Lateral wall, opening of the Eustachian tube or the auditory tube. Then we have the key features. It contains the pharyngeal tonsils or the adenoids in the roof and the posterior wall. It opens off the auditory tube on the lateral walls. It also consists of pharyngeal recess behind the tubal elevation, and it's lined by the respiratory mucosa. This is optional to fill your paper. Coming to the major part, that's the Voldier's lymphatic ring. It comprises of the pharyngeal tonsil. The adenoids are also called as the nasopharyngeal tonsil. It's found in the roof and the posterior wall of the nasopharynx. The tubal tonsils, they are paired. They are present around the auditory tubes. Then we have the palatine tonsils. They are also paired. They are present in the tonsillar fossa of the oropharynx. Then we have the lingual tonsil, lymphoid tissue at the base of the tongue. Now this is again optional. It's like a key point. We have lateral pharyngeal bands and posterior pharyngeal wall follicles. Then we'll draw a label diagram. These are the nasopharyngeal tonsils. These are the tubal tonsils. They are paired. So we have 2. This thing here is the cleft, so it's called as the intratonsillar cleft. These are again paired palatine tonsils. And lastly, the one present below is the lingual tonsil. Okay. So next we'll cover the palatine tonsil. In Latin, it means swelling. This tonsil is seen through the mouth. It's almond shaped. The bed of the tonsil consists of one nerve, two fascia, and three muscles. The one nerve will be the glossopharyngeal nerve. The two fascia are the buccopharyngeal fascia and the pharyngobasilar fascia. The three muscles are palatopharyngeus, stylohyoid, and superior constrictor. The arterial supply is by the tonsillar branch of the facial artery. Nerve supplies by the glossopharyngeal and anterior palatine nerves. Clinically importance, we can say that of the adenoids. If we have a swelling, they can obstruct the nasal breathing and cause otitis media. Palatine tonsil infections can lead to tonsillitis and peritonsillar abscess. And Waldeyer's ring, it forms a protective immunological barrier. So this clinical importance, or you can write as applied anatomy. So this completes your 5 marker. Let's move on to the next question. That's the vertebral artery. Okay. This is again a 5 marker. It's the first and largest branch of the subclavian artery. It's one of the two principal arteries that supplies the brain, spinal cord, and the meninges. Okay, it's divided into 4 parts. And we have the first part. It originates from foramen transversarium of the 6th cervical vertebrae. It runs upwards and backwards in the splenovertebral triangle. Then we have the second part. It runs from C6 to C1. It's accompanied by venous plexus and a large part of stellate ganglion. Then we have the third part. It's called as the Atlantic or suboccipital part. Atlantic because it winds around the atlas. Suboccipital because it lies in the suboccipital triangle. Then we have the fourth part. It extends from the posterior atlanto-occipital membrane to the lower border of pons. It pierces the dura and arachnoid matter and it enters the cranial cavity from foramen magnum. Now the right and left vertebral arteries will join to form a basilar artery. Now let's see the development. Okay, the 4 parts. The first is from the branch of the dorsal division of the 7th cervical intersegmental artery. The second is from the postcostal anastomosis. The third and fourth are from the 1st cervical intersegmental artery. Coming to the branches. The first part has no branches. The second and third part give rise to the cervical branches, that's the muscular and spinal. The fourth part gives rise to the cranial branches, that is the posterior inferior cerebellar artery, the anterior spinal, the posterior spinal, the meningeal and medullary. The vertebral artery terminates by joining the vertebral artery on the opposite side to form a basilar artery at the lower border of pons. Now, to get extra points in the answer, we'll write applied anatomy or key points. We have vertebro-basilar insufficiency, which causes dizziness, vertigo, diplopia due to reduced blood flow. Then we have the subclavian steal syndrome, where there is reversal of blood flow, and any injury to the neck fractures will cause injury to the basilar or the vertebral artery. Now, every answer, a diagram is a must. Now, as we all know, the vertebral artery starts from the sixth part, C6. So, this will be the first part of vertebral artery. It travels all the way up to the spleno-anterior triangle, and here it gives the second part. It winds around the atlas to form the third part. Then it joins the vertebral artery on the opposite side to form the fourth part. Okay, so one diagram and all this will fetch you 5 marks. Let's move on to the next question. Development of palate and its anomalies. Anomalies will be for 2 marks and development of palate will be for 3 marks. Development of face takes place from the frontonasal process and the first pharyngeal arch. It's also called as the mandibular arch. Now this mandibular arch gives rise to the maxillary process and the mandibular process. Okay. So briefly, roughly जैसे भी draw करो, but a diagram is important. Before we go into the development of palate, development of face के लिए just draw 2 diagrams. Okay. This is the frontonasal process. ये nasal pits. This is your maxillary process. And this is your mandibular process. Okay. Now, this is the initial stage. On further development, ये frontonasal process. This is lens placoid for development of eyes. The light blue is the medial nasal process. Dark blue is lateral nasal process. Yellow is maxillary process. And orange is your mandibular process. Just the diagram. We are not going to explain anything in detail here. इसके बाद let's move on to development of palate. So now from each maxillary process, plate-like shelf grows medially. So we have 2 maxillary processes as we see here. So 2 plates will grow medially. So now we have 3 components from which the palate will be formed. This is the 2 from the maxillary process and 1 from the frontonasal process. Initially, the palatal processes are vertically oriented on either side of the tongue, and during the 8th week of intrauterine life, this vertical will change into horizontal because the tongue descends down. Each palatal process will fuse with the posterior margin of the primitive palate. The primitive palate is from the maxillary process. The 2 palatal processes will fuse at midline, which starts anteriorly and separating the nasal cavity from the oral cavity. The union of the 3 palatal shelves is marked by the incisive papilla. इसके बाद just draw a diagram. This is your primitive palate, which comes from the frontonasal process. The blue one is your maxillary process. Now this maxillary process gives rise to two palatal processes. ये primitive palate, ये maxillary palate. Now it fuses. This was during the 8th week. Now they become horizontal. So the primitive palate fuses with the maxillary palate and the palatal processes. Now here the intersection of all the three, 1, 2 and 3 is the incisive papilla. Okay. Coming to the anomalies of the palate. Can occur due to failure of fusion with the primitive palate, maxillary process, or the palatine or the palatal processes of maxilla. Okay. Failure can happen anywhere. So to give this, we have called as the views classification. Class 1 is cleft of only the soft palate. 2 will be soft plus hard palate. 3 will be soft palate plus hard palate plus alveolus plus lip. If all this occurs unilaterally, it's called class 3. But if the same thing happens bilaterally, it's called class 4. Clear? So this completes your next 5 marker. Okay, let's move on to the next question. Describe the origin, insertion and nerve supply of the extraocular muscles. This is again a 5 marker. Okay, first the muscles will be divided into two, that is voluntary and involuntary muscles. The voluntary muscles, we have 4 recti muscles plus 2 oblique muscles plus levator palpebrae superioris. So we have 4, 5, 6 and 1, 7. We have 7 voluntary muscles. So first we'll see all the superior rectus, inferior rectus, medial rectus and lateral rectus. These are the 4 R muscles, 4 recti. So their origin is from the common tendinous ring, all the 4 muscles, and insertion is according to their name. Superior into the upper sclera, inferior into the lower sclera, medial into the medial sclera and lateral into the lateral sclera. Okay, so their nerve supply, all except the lateral rectus are supplied by the oculomotor nerve. Only the lateral is supplied by the abducens nerve. Actions: superior will cause elevation, inferior is depression, medial is adduction, that is towards, okay, and lateral is abduction, that is away. Then we have the 2 oblique muscles, okay, the 2 O's, superior oblique and inferior oblique. Superior arises from the body of sphenoid and inferior is from the maxilla. They insert into the posterolateral sclera. Superior oblique is supplied by the trochlear nerve and inferior is by the oculomotor nerve. As the name suggests, superior will cause intorsion, that means inward movement of the eye, and inferior oblique will cause extorsion, that's outward movement of the eye. Coming to the last muscle, that's the levator palpebrae superioris. It originates from the lesser wing of sphenoid, inserts into the upper eyelid, supplied by the oculomotor nerve, and it assists in elevating the upper eyelid. So these complete your voluntary muscles. Coming to the involuntary muscles, we have three. Okay. Superior tarsal muscle, inferior tarsal muscle, and orbitalis. Superior tarsal arises from the inferior surface of levator palpebrae superioris, inferior tarsal from the inferior rectus muscle. Superior originates into the upper border of the superior tarsal plate and inferior from the lower tarsal plate. Orbitalis, it spans across the inferior orbital fissure and connects to the periosteum of orbit. All these three muscles are supplied by the sympathetic. The action, superior assists in elevating, inferior in depressing, and orbitalis maintains the forward position of the eye, nothing but the tonicity of the eye. So, coming to the clinical anatomy, applied anatomy, paralysis of these muscles can occur due to the loss of sympathetic nerve supply, which causes ptosis or drooping of the eyelid, and enophthalmos, that is sunken eye, which is usually seen in the Horner's syndrome. The upper muscle here that you see is the levator palpebrae superioris, and this is superior rectus. This is inferior rectus and this is inferior oblique. This is the tendons capsule, that's the originating point of the muscles. This is the epicranial space. This is the medial check ligament. This is the lateral check ligament. And this is the suspensory ligament of the eye. Okay, so this completes your another 5 marker. Let's move on to the next question, that's the thyroid cartilage. This is again a 5 marker. Thyroid cartilage is the largest laryngeal cartilage. It's made up of the hyaline cartilage. It's V-shaped in cross section. It consists of the right and left lamina. It's roughly quadrilateral in shape. The lamina are obliquely placed relative to the midline. They approach at 90 degrees in male and 120 degrees in female. Okay, this prominence that is formed here is called the Adam's apple or the laryngeal prominence. Superiorly, the superior horn, it connects to the greater corner of the hyoid bone, and inferiorly it articulates with the cricoid cartilage to form the cricothyroid joint. Now we'll draw one diagram. Now the first one is epiglottis. This is our hyoid bone. This is the thyrohyoid membrane. This is thyroid cartilage. This is the oblique line of thyroid cartilage. This is cricoid cartilage. This is trachea. We have 3 muscles also. This is thyrohyoid, sternohyoid, and thyropharyngeus. Okay, now we will write about the attachments. Superior border attaches to the thyroid membrane and median thyrohyoid ligament, inferiorly to the cricothyroid ligament. Superior horn or the cornua attaches to the lateral thyrohyoid ligament into the hyoid bone. Inferior horn articulates with the cricoid cartilage. Outer surface attaches to all the muscles: sternohyoid, thyrohyoid, inferior pharyngeal constrictor. Inner surface attaches to the ligaments. The posterior border attaches to the palatopharyngeus and stylopharyngeus muscle. Okay, again we will draw one diagram. Now this is epiglottis. This is thyroid cartilage. This is the arytenoid cartilage. This is the cricoarytenoid joint. This is lamina of cricoid. This is cricothyroid joint, and this is trachea. The more diagrams you draw, the more marks it fetches. Okay. Lastly, to get extra points, we will write the applied anatomy. Adam's apple. In males, as we know, it forms an acute angle 90 degrees. It's a clinical landmark. Female में 120 degrees. During cricothyroidectomy or laryngectomy, the thyroid cartilage is a landmark for emergency airway access. Age changes are shown. Ossification occurs at the age of 25 to 30. Trauma or fracture of the thyroid cartilage may occur during strangulation or blunt neck injury. Thyroid cartilage acts as a surgical landmark to locate the vocal cords during laryngoscopy. This completes another 5 marker. So coming to the next 5 marker, that's the tympanic membrane. It's a thin, translucent partition between the external acoustic meatus and the middle ear. The main key role here is sound conduction. It's oval in shape, measuring about 9 into 10 mm. It's placed obliquely at an angle of 55 degrees with the floor of the meatus. The membrane has 2 surfaces, the outer surface and the inner surface. Outer is thin and it's lined by the skin, which is concave in shape. The inner portion provides attachment to the handle of malleus, which extends up to its center. It's convex in shape. The point of maximum convexity is called the umbo. After this, we will just draw a small diagram. This is the head of malleus. This is chorda tympani. This is the handle of malleus. And this is pars tensa, the larger portion. And this is pars flaccida, the smaller anterior portion. Now we'll discuss both of these in detail. We have the pars tensa. As we saw, it's a large tense portion. It makes up most of the membrane and it's responsible for vibration and sound transmission. While pars flaccida is a smaller superior triangular portion. It's present between the anterior and posterior malleolar folds. Coming to the layers, it has 3: outer, middle and inner layer. Outer is skin, middle is fibrous and inner is the mucous membrane. Blood supply is divided into the external and internal surface. External surface is by the deep auricular branch of maxillary artery, while the internal surface is by the anterior tympanic artery and the stylomastoid branch of the posterior auricular artery. Coming to the nerve supply, external and internal. External is by the auriculotemporal nerve and auricular branch of vagus, also called as the Adlon's nerve. Inner or internal is by the glossopharyngeal nerve. Again, here we'll draw two small diagrams stating the layers of the membrane. This is the outer layer, that is the skin. This is the middle layer, which is fibrous. This is the inner layer, which is lined by mucous membrane. So we have outer, middle and inner. One more diagram showing the fibers would be, this is the anterior malleolar fold. The small anterior triangle is the pars flaccida. This is the posterior malleolar fold. These are the deep circular fibers, and these are superficial radiating fibers. This, as we know, is the handle of malleus. Okay. Now coming to the lymphatic drainage is by the preauricular and retropharyngeal lymph nodes. Venous is again divided into outer and inner. Outer is by the external jugular vein. Inner is by the transverse sinus into the venous plexus around the auditory tube. Then key points, we will just write applied anatomy, which will fetch you extra marks. Is otitis media is nothing but infection of the middle ear. Perforation is due to infection, trauma or barotrauma. Barotrauma is nothing but air or water pressure. Myringotomy is surgical incision made in the posterior inferior quadrant to drain the pus. Tympanoplasty is surgical repair of perforated tympanic membrane, and otoscopy is the normal membrane appearing pearly grey in cone of light. So this completes your another 5 marker. Let's move on to the next question. We have inferior alveolar nerve. This is for 5 marks. So we'll write a brief intro that we'll talk about the development this time. It's derived from the posterior division of the mandibular nerve, which is a branch of the trigeminal nerve. The mandibular division is the branch of the first pharyngeal arch. Hence, it supplies all the structures that are derived from this arch, like the muscles of mastication, mylohyoid, anterior belly of digastric, and many more. Okay, so now we have to write about the branches of the mandibular nerve. You can write it in two. Either you can write it in this, a tabular form, or you can write it in the form of a flowchart, however you feel comfortable. Okay, so for people with the tabular column, you can write the stages before entering the mandibular foramen, within the mandibular canal, at the mental foramen and the terminal branch. Before entering the mandibular foramen, it gives a branch called as the mylohyoid nerve, which supplies the mylohyoid muscle and the anterior belly of digastric. Within the mandibular canal, it gives rise to the dental and gingival branches. Dental will supply the mandibular molars and premolars, and the gingival branches will supply the buccal and lingual gingiva of the mandibular teeth. Then at the mental foramen, it gives rise to the mental nerve, which supplies the skin of the chin, lower lip, labial gingiva of the anterior teeth. The terminal branch is the incisive branch, which supplies the mandibular canine and incisors. So this is the tabular column. Okay, now let's move on to the flow chart. Then we have the mandibular nerve, which gives rise to the inferior alveolar nerve. Okay, this gives off a branch called the mylohyoid nerve before entering the foramen. That's the mandibular foramen. Once it enters, it gives branches to the inferior alveolar nerves and vessels. It runs in the canal. It supplies all the mandibular teeth. Then, at the mental foramen, it divides into the mental nerve and the incisive branch. The mental nerve supplies the chin, lower lip, labial gingiva, and the incisive branch will supply the anterior mandibular teeth, that is incisor plus canine. Now for this you can just draw a diagram. So this is your mandible. ठीक है? अब ये the one that is coming behind all this teeth is your mylohyoid nerve. The one that's entering into the mandibular foramen from here to here is your inferior alveolar nerve. Now at this mental foramen, it comes out of the foramen, turns around, it forms a loop here. This is the loop. It's called the mental nerve, and the branch that goes straight is the incisive nerve. Then we have the applied anatomy. Inferior alveolar nerve block is the commonest nerve block for any technique in the mandibular teeth. The site of injection is the mandibular foramen. It anesthetizes all the mandibular teeth, the labial gingiva, skin of the chin and lower lip. Complications of the block include hematoma, trismus, and accidental paralysis of the facial nerve. The clinical correlations would be if there is a mandibular fracture, it may damage the inferior alveolar nerve, which will cause numbness in the chin and lower lip. The pathologies like the cyst and tumor in the mandibular canal may cause paresthesia. Surgical relevance is that we have to be very careful when we are doing mandibular osteotomies, implant placement, and third molar surgeries. So this completes your another 5 marker. Now we have covered all the 5 markers. Let's move on to the 2 markers. That's the frontal nerve is the first 2 marker. So it's the largest branch of the ophthalmic division of the trigeminal nerve. It runs forward in the roof of the orbit where it divides into the supraorbital and supratrochlear nerve. Supraorbital will supply the scalp, forehead, upper eyelid, and supratrochlear will supply the medial forehead, upper eyelid, and conjunctiva. Next we have the epicranial aponeurosis. Again, this is a 2 marker, is also known as Galea aponeurotica. It's a key anatomical structure of the scalp. It's a broad flat sheet of dense fibrous connective tissue. It extends anteriorly with the frontalis, posteriorly with the occipitalis, and laterally it blends with the temporal fascia. So this is the boundaries. So frontalis belly is present in the front of the forehead, originates from the epicranial aponeurosis. It inserts into the skin of the eyebrows and root of the nose. Occipitalis belly arises from the back of the head, that's above the occipital bone. It originates from the superior nuchal line and inserts into the epicranial aponeurosis. The function of the frontalis is to raise the eyebrow and have wrinkles on the forehead, while the occipitalis belly will pull the scalp backwards. Okay, so the next one is a little tricky question. They have asked us to draw a label diagram of the histology of pancreas for 2 marks. So quite not possible, but since they have asked, now the pancreas, as we all know, is a mixed gland. Okay, it comprises of the exocrine part and the endocrine part. Now, the exocrine is mainly responsible for producing digestive enzymes. So it consists of all the serous acini, acinar cells and the ductal system, while the endocrine is responsible for secreting hormones like insulin and glucagon. So we have pale staining clusters scattered among the acini. That means it has small centrioles of clusters present. So for the endocrine part, we'll just draw a circle as you see here, okay, with a large center containing the alpha, beta cells and also the red color capillaries. Now while for the exocrine part, okay, as we have the ducts and acini, we will draw a serous acini, okay, and the pancreatic islets in the center, which are separated by the interlobular ducts, and in between these we will have the intralobular ducts. So brief diagram of all this is just enough. Coming to the last question, that's the boundaries and aspects of the pyriform fossa. It's a pear-shaped recess on either side of the laryngeal inlet. It guides the food away from the laryngeal inlet to the esophagus. Now they have asked us the boundary. So medially it's by the aryepiglottic fold, laterally by the thyroid membrane, inferiorly it's continuous with the esophagus, anteriorly we have the posterior surface of the thyroid cartilage, and posteriorly it's the pharyngeal wall. The applied anatomy is, it's a common site for lodgement of fish bones and foreign bodies, which causes pain and dysphagia. And this has a very close proximity to the internal laryngeal and recurrent laryngeal nerve because they lie below it, and there is a risk of injury during removal. Carcinoma of the pyriform fossa is also common, and it may present late due to its hidden location. So now with this answer, we complete the July 2015 Human Anatomy paper. So that's a wrap for our July 2015 Human Anatomy paper. Don't forget to like, share and subscribe for our next PYQ discussion.